Start the clock. I have also been informed that there's a small football game going on right now. And Dr. Jarvis and Ellerby, I believe, want to watch the LSU game.
In case you're wondering what that game is, that's actually the Aggie game.
You can call it that if you want to. So I went to LSU, and y'all went to that other place, right? So I think this committee will continue in the bar once we're done. So I only got alibis from one of the committee members, Dr. Don Phillips. This would have been his last meeting, and he sent me an email that he wasn't going to be able to make it. I sent him back an email that said, well, I guess that means I can't kick you off the committee, or it wouldn't do any good to threaten you that. I got the very adult nanny boo-boo back from that. So unfortunately, he is not here. We do get to recognize him for his service, as this is his last meeting. And hopefully he will be at the council on Monday. Aside from that, the only other person I have who are the other two that I have that are not present now are Dr. Serbaugh and Bradley. I believe everyone else is here, and we have a quorum. Has anybody seen those other two? Nope. Okay. So we do have a quorum. That constitutes our roll call. I'll pull everyone's attention to the vision and mission. I'm not going to read it because I believe we all can. And then jump right into number one, which actually I'm going to ask Dudley to come forward to discuss, because the EMS committee has been doing quite a bit of work on this particular issue with the meetings around the state. This is in regards to review of DSHS. And I will turn it over to Dudley. You only have 88 minutes. Just saying.
I also have great interest in watching the University of Texas play football against LSU. So,
You gonna let him by with that too?
Absolutely, we are the university.
So, the 83rd legislature passed two pieces of legislation dealing with fraud in the EMS industry. There's a rule change being proposed for that be discussed at the EMS committee tomorrow, and will be hopefully approved by GTAC on Monday. The other piece of that, though, in Senate Bill 8 was a requirement for DSHS, the Texas Medical Board, and the Health and Human Services Commission to do their own stakeholder input sessions to look at different areas of fraud in the ambulance industry and how to address it. And the DSHS piece was how to address fraud, how to better regulate the non-emergency ambulance, or the non-emergency transportation piece of the ambulance industry. And so the EMS committee took that on and said, you know what, we'll go around and do these stakeholder meetings, and our new state EMS director, Joe Cmte, was brave enough to accompany us across the state. And since we last met in August, we've been to Houston, Harlingen, Amarillo, Dallas, Austin, and San Angelo to meet with stakeholders. We've met with over 400 stakeholders, representing probably about 33% of the licensed transport providers in the state of Texas. And did a lot of just listening to things they thought would make the industry better. And we came up with basically 5 broad areas that we're going to take to GTAC for giving to DSHS, so hopefully that they can be included in their report to the legislature that's due in January. The first one is to increase education and accountability on EMS personnel, healthcare facility personnel, i.e. hospitals and nursing homes, Medicaid managed care personnel, and patients regarding the proper use of ambulance transportation. And the accountability piece lies on all those folks except for the patient, but we think patients need better education so that they don't get pulled into schemes of people who are trying to be fraudulent in reimbursement. But there's a lot of discussion all over the state of Texas, even in areas where there is no issues with fraud that we normally think of, about how facilities are, I don't know the right word, I don't want to say enticing, but they're sometimes pressuring 911 agencies even to take patients by ambulance that don't need to go by ambulance because of either political pressures in that community or other system pressures to try to get them to take that, and that's putting a burden on some of these agencies. So a lot of ideas underneath that category to address all of those areas, and I'd be happy to share those more in detail. But the second area that came up as an overall theme was increase the number, ability, and processes of DSHS EMS regulatory personnel. It's weird to hear people say we need more police, but we need more police. A lot of the folks all over the state, you get out of the large metropolitan areas, they're like, please, no more regulation. There's a problem because we can't enforce the regulations that are there now, and so the stakeholders as a whole were voicing concern that we don't have enough folks doing the regulation, and that maybe the problem isn't we don't have enough rules, it's just we're not enforcing the rules that we got. And so a lot of that is addressed at more regulatory personnel, mandating for new providers that they get an unannounced on-site visit within 6 months of them starting operation, instead of getting it and then going into operation knowing they're not going to see DSHS for a year or two unless it happens to be at a hospital.
Say that again. You said not more rules, but more.
Not more rules, but more regulation, more enforcement of the rules that are already there. Okay. And so several items underneath that as well. The third area was there should be one type of license for all ambulance providers regardless of their primary service type. And one of the things that has come up time and again has been, should we maybe have a non-emergency provider license and an emergency provider license, and then the emergency would cover, you could do both, but the non-emergency could only do non-emergencies. And across the state of Texas, and surprisingly so, I think everybody there was surprised. In the rural and frontier areas, even more so, they did not want to see a division of the license type. And a lot of things came up about that. If you're going to say it's an emergency or non-emergency, what definition of that do you use? Using lights and sirens or not using lights and sirens? The billing definition, some level of criticality of the patient. How do you do that? And so the thought was we need one provider license type so we can apply the regulations to everybody, because even the non-emergency providers, and sometimes even more so with some non-emergency providers, they're carrying a higher criticality of patient than other services carry. And so the thought was that we need to continue to enforce, but we need to enforce it on everybody. And a piece of that came out of that in a couple of meetings was that not only do we need to have one license type, but we need to really look at the other provision of transportation of patients that could be termed medical patients. And that is stretcher transport, where they're unattended in the back, and wheelchair transport, where medically fragile people are being moved. Not that we need to regulate them and they need to provide medical care, but they're not being regulated today other than a permit to make sure that they're not a child molester, and the taxi division of a city is saying you can go out and do that. But do we need to regulate the overall transport piece of people who are going for medical care, even though if they're not classified as a patient at the time of that transport? So that was a kind of a unique thing that came out of that. Number 4 was updates, enhancements, and refinements to some of the changes being proposed out of these pieces of legislation. Some of the things that are in there are requiring jurisdictional approval of where new operators can operate for their first 2 years, and the stakeholders felt that should possibly be extended past 2 years. Changing some of the exemptions to some of that. A lot of the exemptions in that new law exempt out agencies that are directly operated by a governmental entity, but that does not exempt a lot of the 501c3 volunteer providers in the rural and frontier areas. And so there's some concern on their part that this may be a little heavy-handed on them, and so maybe we could get that addressed as well. And then the other thing is that it requires more requirements. The new law required in rural, that'll be approved by GTEC hopefully, it required additional requirements on the administrator of the service. And across the state of Texas, the stakeholders believe those requirements should apply to the administrators of all EMS agencies, not just private for-profit agencies. Because it requires education, it requires continuing education, and those type of things that EMS operators across the state, in general, need more of. And then lastly was increase the requirements of legitimate business practices. And these were some things we'd heard over the years, and a lot of stakeholders across the state brought up different things like requiring somebody who's putting in for an EMS provider license to show proof that they own a business facility or lease a business facility, and that that's actually where they do their business out of, so that when DSHS shows up to inspect them, it's not a vacant field with a mobile mini storage unit in the middle of it. Making sure that they have proof of ownership or leasing of the equipment that they're going to use, like ambulances, stretchers, heart monitors, AEDs, whatever it is, so that we know the equipment they have, they're not borrowing from their friend down the street, but it's actually theirs and it's going to be used on their vehicles. Let's see. And then lastly on that was from the stakeholders was developing a plan, a 5-year plan to require all EMS providers to be in electronic charting within the next 5 years. And so that was to help both with compliance as well as helping agencies that need the assistance with better reimbursement, because the documentation is better in that environment than it is a handwritten environment. So those were the 5 areas that we came up with, that we brought up in the report. Overall, it was very eye-opening. I think our new state EMS director may want to speak to some of that, but it was very eye-opening and refreshing to get out there. They were all very well attended, except for the one in Austin. But we got away from Austin, and people came out of woodwork and wanted to talk. So,
Dudley, the last thing you mentioned there about the EPCR, the universal requirement, was there discussion about any particular criteria like NMSIS compliance? Or?
Not really. The focus wasn't on NMSIS compliance. I think the free market's kind of taken care of that. That would probably be something we could flesh out later. I don't think anybody would be opposed to it being NMSIS compliant, but it wasn't on the data collection side. It was on the reimbursement side, and the ability to more quickly track fraudulent efforts at billing was to be going through electronic records instead of handwritten paper records.
Any pushback from the services that can't afford or feel like they can't afford electronic documentation?
No, it just came up in several sites. Nobody said, "Ooh, we can't do that." I mean,
Okay.
you know, I think, I don't really know what that number is. I think it's probably a pretty large percentage already that's doing it. But nobody said, "Oh, that would kill us," or anything else. It was just one of the ideas. I mean, we just basically had brainstorming sessions and wrote down every idea, and if it appeared multiple times, or if it was a passionate discussion topic, we included it.
Dudley, did the use of first responder organizations ever come up? And I'm just a little worried that we don't have a lot of control over how those units are staffed, or who's qualified to do what, or who's monitoring any of that.
You know, first responders, I think that came up a few times, but the way we rolled it out was we showed them Senate Bill 8, where it talks about the non-emergency transportation piece. And so we never really, we tried to stay focused on that. And even still, our first bullet point probably goes into HHSC's stakeholder input, not ours, because it's all about fraudulent reimbursement and how that occurs. But we felt strongly enough because it was clearly present all over the state. But we didn't really dig too much into first responder activities. Came up a few times, especially out in the rural areas. More of that was just helping them understand how the rules work and that kind of stuff. So.
Any other questions? And you'll be reporting to GTAC, and do you have a document to give to GTAC?
Yes.
Okay, all right.
And if y'all like that, I'd be happy to send it to you. It's a draft document right now. The EMS committee has not approved it yet. I mean, our last meeting was about 10 or 12 days ago. So we've not had a committee meeting to actually approve it. We're going to be approving it tomorrow, but then forwarding it to GTAC for their approval. So they either have or will be getting the draft of that document, and so they have time to review it.
Okay.
But if y'all want, I'd be happy to send it to y'all and let you read it.
Does anybody have any heartburn with any of the specifics that Dudley mentioned? This will go through GTAC. Is there anything particular? No? I mean, it sounds good to me.
My only one is the NMSIS compliance. If we're going to, you're right, I think a majority of the EPCRs have that, and I would hope that people would have the foresight to buy one of those. But if we're looking at a meaningful registry, I think NMSIS is the way to go.
And that would be a pretty bold step for Texas to require something like that, even with 5 or 7 years notice. Probably as bold as the accreditation stuff. And I think we would have similar discussions where we could make sure that it was an appropriate vendor as well.
Yeah, when you said that, my eyebrows went up. If we're going to make that leap, I think the leap to NMSIS is pretty easy.
Pretty easy. And then that helps trauma registry, state EMS registry. I mean, all of a sudden it helps everything. So.
And then one other thing you mentioned that I'm going to see if the committee is interested in, or if this is a topic for anybody. You mentioned some EMS services are being asked or forced to transport patients that don't really need it. The issue I keep seeing coming up is hospitals that require any transfer out of their hospital to go by ambulance because they're a transfer, and they quote EMTALA, which is totally wrong. It is not required by EMTALA. It's not required by anything. But that does put a burden on some EMS services. Does that seem to be a big enough issue that we even need to come up with a position statement on, or because?
So as an EMS provider, I'll tell you, I think that would be huge if the medical director said something about that. The primary issue where this, and I'll tell you a primary issue and then a couple ideas we had to address it. One was the primary issue is a facility, and it could be any facility type. It's not a hospital per se all the time or a nursing home per se all the time, but a facility will call up the provider that they normally use. And in some communities, it's the only provider in town. And they will say, we need you to come get this patient, and they get what's wrong and say, well, that patient doesn't meet medical necessity, we can't really transport him by ambulance. Well, the doctor signed the PCS, or the doctor, I've got orders here, the physician saying we should move him by ambulance. Well, I understand that, but we're not gonna get reinforced. If you don't do it, I'll call somebody else. And then that agency, the community agency, 2 or 3 hours later, sees an ambulance sitting in front of that facility moving that patient out. And so we thought better education for the facilities, and some of these agencies operate other means of transport. They operate wheelchair transport and those type of things as well. So it's not like there weren't other options. And what they're doing is they're pitting these folks against, and in the metropolitan areas even more so with the folks that are in this business and contracting with these, they're pitting them against each other. They're saying, if you won't do it, I'll find somebody who will do it. So we thought, first of all, requirements from HHSC on education to these facilities and their personnel about what medical necessity was, and the fact that those facilities are at risk for trying to pressure an agency into doing that. And then the other thing was to come up with something like some of the air medical agencies have come up with. So if Dudley's ambulance service calls for a helicopter, I call helicopter service A, and they say we can't fly because of weather. If I'm going to call helicopter service B, depending on the rack, either there's some place they can look to see if that flight's been turned down, or I really need to tell helicopter service B that we tried A and they said no due to weather. What we want to see is a very similar thing on this. And if you call my ambulance service, and I say that patient doesn't meet medical necessity, that gets entered into a database. And if an ambulance takes that patient within so many hours, that's an immediate eye-opening experience for somebody to go look at that to see if something was done inappropriately. So those are the two things we were looking at to address that.
Okay. Is that of interest to the committee? Because we get caught in this a fair amount, at least I have.
You know, it just kind of comes down to what I understand the state position has always been, is that the sending physician determines the mode of transportation. And so if you're going to educate people, that's the person that needs to be educated apparently. If the physicians are making bad choices, you know, maybe the Board of Medical Examiners could send out a notice to the physicians that you need to do what's right for the patient when it comes to transport decisions.
We thought it wasn't a lot of smaller communities, and depending on the facility type, that physician may not always have the clear picture of what it is that supposedly they're ordering to be done.
Correct.
And Dudley, that to your initial point, which was education.
Yeah.
You know, a lot of the times in the emergency department, when a patient needs to go from point A to point B, you know, the physician winds up dealing not only with making that decision about medical necessity, but then dealing with the family afterwards. And I think a lot of decisions are made based on fear of the fight, I hate to say, but I think education ought to be really at the very beginning of all of this for all levels.
Absolutely.
I agree. All right. Thank you, sir. Thank you for all the work you did going all over the state.
Thanks, Dudley.
Yeah.
Thanks, my committee. They did all the work.
All right. I'm going to skip because we have another guest, Mr. Fillingham. I'm going to say this wrong. I'm sorry. HT. Where's he at? There you go. I can screw up anybody's name, and yours is no different. This is from the Stroke Committee to discuss CE hours for EMS providers for stroke. He did. I think everyone has a handout that you provided. So I will turn the floor over to you.
Thank you. What we'd like to do is just present you guys with this idea and solicit some input and hopefully get some support for it. What we'd like to do is to require, right now we're talking about 4 hours in a recertification period, which is 4 years. Stroke-specific CEs, we don't have that right now. The handout I gave you has, the first page is the number of hours for each skill level in EMS that we have to have for recertification. The content area is on the next couple of pages, and if you'll notice, the closest thing we have is under medical is neurology. It's not specific to anything, okay? So that there's a number of things that can fit into that category. And we would like to add stroke-specific information here, okay? I included the national rating. I'm sorry?
Live CE, or could some of that be online?
No, it can be online. What the proposal is the state would implement this as a policy, which would allow existing for example, services who have their own CE programs in-house, all they have to do is adapt and include some stroke into it. It's not going to be a specific, in other words, we're not going to set up a design course for them. It's going to be something that everybody's going to be able to incorporate into what they need. Because certainly, your larger metropolitan areas and your larger services may have a stroke center sitting on every corner, or you may be from my country and the closest level one's 2 hours. Okay, so it's going to be different for us. We're going to have to, ideally we would like for just simple things like basic recognition, kind of work our way up into things like transport considerations. Hey, if you're in town and this is good, but if you're in the country, consider this, think about this. So that everybody in Texas, for every skill level, gets a little bit of refreshment on stroke, or and hopefully as things change and improve, so do our city programs, and it stays current what the current treatment and modalities are. So I included the national registry in there, and I apologize for the fact that it's very small. I'm as computer literate as a fence post, and I couldn't get it going bigger without doing really weird things. So, but that's off their website. But nobody's really right now requiring any stroke specific CEs, and that's what we would like to do.
So what you would be proposing then is you would, in addition, you would essentially break out medical and require something on stroke?
Yeah, if you look at the first page, and I'm going from the paramedic end of it because that's what what I am and what I look at. It says additional units in any approved category. There's 36. We would move 4 of those into stroke-specific type stuff. Okay. If you look, I think the 4th or 5th page has got what we call our card courses. Those are things that the state recognizes, standardized training courses. This stroke CE, we don't have anything like that for stroke. Some of these, ACLS has some stroke things in it, but it's, we feel like a little bit more brief than it should be. So what we want to do is, and it won't add hours to recertification. It'll simply move some of the available things that we can, quite honestly, there's a lot of things in that 36 hours for a medic that you can take that are more enjoyable than training for us in a sense. We'd like to bring the stroke up and have folks be able to get refreshed on that and be a requirement.
So what would your thoughts be if you, and I'm not saying this is a thing to do, but the counter argument would be, as soon as you say we're going to require 4 hours for stroke, then we're going to have 4 hours for cardiac disease, then we're going to have 4 hours for endocrine disease, and those categories, I'm sorry, I still sit kind of funny from the public forums that I led maybe 25 years ago when we first went to this. And there was a lot of discussion about how specific do we want to get. I'm not sure that it really matters to me one way or the other, but so what are your thoughts about, do we stop at stroke or do we uber specialize in requirements?
I think stroke has proven to be a growing problem for us, and I think it's something that we need to focus on a little more than we are. Certainly, the 4 hours, and the state will approve the content from their vendors that provide this stuff and approve the programs and so forth. But I think that I think we're getting to a point that we need to get together and be on the same page when we start dealing with stroke, because what I'm seeing out in the country is our doctors want us to bring that patient to our hospital and just blatantly put, they'll walk up and look at, yep, he's having a stroke, where's the helicopter? Well, we could have done that from the scene, saved a lot of stuff, and we're not really getting the consideration, the training, hey, think about this, look at this. And that's kind of what we want to do. We feel like it's an important enough problem, and it's a growing enough problem, and we have doctors and facilities that are beginning to ready themselves to see these patients and take care of them. And we need to be in the EMS pre-hospital. We need to be thinking in terms of what's best for our patient. Where does this guy need to be, and how can we get him ready to put us? So.
Have you presented this to the Education Committee yet?
They're next. So, yeah. But like I say, we just kind of want to get started. It's not something that, do we plan to have an 8-hour or 16-hour card course for stroke? Not right now. We would just like to get folks together and periodically refresh and review these things.
I think the bigger issue is competency. And as National Registry moves to the portfolio, I think that mandating NECE is probably going to be somewhat antiquated because it's going to be based upon what experiences and exposures with a progressive QI program that your entity has. So if I'm an individual and I've just ran 10 neurological emergency calls this quarter, my CE needs to be in something that I'm not getting exposed to, and that's the purpose of a competency-based continuing education program, not regurgitation of knowledge you already have. So I think in moving forward, I would suggest that any specialty, be it cardiac, be it neuro, be it whatever, is that we have experiences, exposures, or if not, then an education program in that. And that's where National Registry is moving in all things with the portfolio. And we as EMS professionals need to get our people to start tracking what their exposures are and what skills they are performing, and their continuing education needs to be based upon what they're not doing, not just putting a bunch of numbers to fill a slot on a piece of paper.
And again, a service with a continuing education program such as yours can adjust that program to meet their needs. Okay, for us in the rural area, it's a little bit different. Okay, because we have some different ideas, some different problems that we face. So, and this is just a start, really, a step forward to help get us on the same page and start moving forward. And absolutely, it may change, down the road, and hopefully it will for the better for what we need.
So I can certainly understand the counter arguments and the issues that will be brought up with this, but I think it sounds like you're trying to be rather innocuous and improve some educational processes that are out there, and so I think I would certainly be supportive of it. I mean, stroke care is really one of our core competencies in EMS. Time-sensitive diagnosis. We're building systems around the delivery of care of stroke, so I certainly don't think it's unreasonable to have a 4-hour specific continuing education component around a 4-year period and things like that. So, again, I understand some folks will have some reservations, and completely agree with Dr. Beeson on the portfolio issue, but I think we're going to be a little bit before we get there. And so, even with that, I would be supportive of a 4-year or 4-hour continuing education requirement. I think you have to be careful in how you or use the terminology. Is it neurologic emergencies? Is it specifically to stroke? And those sorts of things for you. But it sounds like you have some more work to do to get that delineated. So.
I would like to add a comment as well. And my comment is that I also support what you are attempting to do. At the state level, we are looking at trauma, stroke, and STEMI. I mean, those are issues that we address at the state level. So I would really support, again, with deference to my colleagues and their viewpoints, but I also live out in that rural area, and so if I don't bring these issues, then the issues don't actually get taught, and in some cases, it helps for there to be a requirement. That's, if I'm not mistaken, that's how we wound up with a little pediatric requirement in here as well. But what I'm saying is that I really believe that we need to have instruction at every level for stroke, and however we get there, I'm not the language person, but certainly that is a key issue of morbidity and mortality in the state of Texas, and it would make a difference, so I would support you.
We might make recommendations that kind of mirrors where National Registry state, so that half of them are mandatory and half of them are flexible. Put it in the medical flexible, so you didn't necessarily have to have all 4 in stroke, but if you could have 2 that are mandatory. But we don't have really a lot of influence on what is mandatory by National Registry. For example, do we really need every time we give a city program to cover near drowning? That's a mandatory National Registry topic. Why? I mean, if you covered it 3 or 4 times. Can you say you covered that one? Now we have to say it's a mandatory every time we got to cover that one subject.
I think it's mandatory because somebody felt it was mandatory and made an argument that it was really important and we should cover it every time.
Right.
Yeah.
Squeaky wheel. Yeah.
So,
Why not?
and again, this is going to grow. There's still the question of, is the state going to keep a state certification? Are we going to go national registry as our recognized certification? And this would just, if it's in place, it would allow us to adjust to whatever we needed to do, but make sure that there's something there for us to refresh on.
Yeah. I think it'll be interesting because I think right now some of the biggest needs for stroke education is in stroke mimics. So, which you could argue is not stroke education, it's the other stuff that looks like stroke.
Right.
So,
Well, you know, the key to anything is first determining what it's not. I mean, that would
Right.
be a significant part of education.
yeah, because right now lots of places are giving TPA to more migraine headaches than to anything else.
And
You laugh.
You may use as one
Yeah,
of
it
your
works very
arguments.
well.
I just sat through a portion of the transition courses, and they were discussing scleroderma was in their curriculum. So I think you probably have a little support there when you move to stroke education.
Thank you.
All right, thank you, sir.
Appreciate it. Thank you.
Thank you.
All right, and once again, since I don't know why I go to the trouble to number the agenda items because I never stick with them. I'd like to jump to what's actually up on the screen right now, item number 6, to discuss and possibly forward to GTAC position statement on mental health care and EMS. I'll turn it over to Dr. Jarvis.
So the thing I have up on the screen is really what the discussion was about. And what I did is updated the draft position statement to include the comments from the committee at the last meeting. And I'll basically just go over those changes.
Yeah, I don't think anybody can see them.
How about I just read the changes and I'll let y'all know what y'all wanted changed. The basic position statement is, it is the position of the Medical Directors Committee of GTAC that number 1, work with, and the way it did read was work with mental health inpatient facilities to create a standard definition of a medical clearance exam. And the way it reads now is we added in local and regional mental health inpatient facilities to create a standard definition of, and instead of mental clearance exam, it says medical stability. And then,
What do you want to talk about? Want to take them one at a time?
sure.
Okay.
So any comments about that? We specified local and regional would include RACs. Mental health inpatient facilities, and instead of defining the medical clearance exam, we now define what medical stability is.
I don't agree. Everybody agree? I don't remember the discussion on this as well as I thought I would have, so.
I think perhaps a lot of it was, the feedback was, well, I'm not sure it's really possible to do that. So we tried to limit the scope just a little bit to perhaps make it a little more feasible. The second statement is work with and I'll read it the way it was and then tell you what changed. It did say work with professional associations representing inpatient psychiatric facilities to get universal acceptance of a medical clearance exam meeting the agreed upon definitions. And this has basically been changed to reflect the changes in number 1. It now says work with professional associations representing inpatient psych facilities to get medical stability, oops, that was supposed to say a definition, or get acceptance of medical stability according to the above definition. So really just incorporating so number 1 is define it, number 2 is get acceptance of that definition.
Agreed. Okay, any other discussion on this one?
Number 3, and again, I'll read it the way it was, determine if there are situations in which EMS personnel with additional training would be able to perform these clearance exams and transport directly to inpatient psych facilities. And some of the comments here were really, we didn't want to limit it just to inpatient psych facilities. So I expanded that definition out and then also made changes based on the prior changes we talked about. So it now reads, determine if there are medically stable patients whom EMS personnel could transport directly to inpatient psych facilities or other non-ED facilities, and then in parentheses it says sobering centers, crisis intervention centers. And then number 4 was left unmolested, and basically it says, let's take another shot at getting emergency detention authorization.
And number 4 is underway. There are TMA, THA, and Texas College of Emergency Physicians will be working on that. If you're a TMA member, you got to see my ugly mug in the journal that just came out this month. So are they, if it is on our agenda that we can approve this, and if we approve it today, it is on the GTAC agenda for Monday. It could be approved by GTAC, or at least GTAC could take it and send it back out, do with it as it pleases.
Well,
Or
this line 3 doesn't really comply with the state law, and that is that the sheriff's department shall transport to the site facility. It never mentions EMS, so can we add EMS and/or
Well, that's
appropriate?
only if they're under an order, an emergency detention.
That always comes later. We're just talking about from the scene to the facility. And the state law is that the scene to the facility should be done by the sheriff's department.
If they're under a cycle, yeah. But these people may not be under cycles. They may be going voluntarily.
Possibly. More likely a cycle, but possibly.
So is that a big, are you saying that's a big enough of an issue to, I'm having trouble reading myself.
Here you go.
Would that be enough to keep us from forwarding this, would be my question. Because I don't think it's in violation of state law. I'm not saying they have to. but
What, to
they
transport
could.
alternative destination?
Yeah.
It's not a
No.
state law, it's just not a billable thing.
Right.
No, I think his point was that the way the law says now is it's the responsibility for those emergency detention folks under OEDs it's the responsibility of SO to transport
Of
them.
the county.
And he wanted that put in there. I don't think it would materially change or weaken the statement, so I don't have a problem.
No, I think
putting
that's
that
going to
in.
be a local jurisdictional decision. I think this gets to the point that we need to get over this transport to the ED for medical clearance issue, and I think that's what it says, that if we do additional training, that's a good song.
I don't think you're allowed to strangle small
Where are
children
you from,
in the
Louisiana?
background.
But I think that says the point is that do additional training, medical clearance, and transport directly to the facilities, regardless of what that mode of transport is.
Well, it's true, this doesn't mandate EMS, does it?
Yeah, because in reality, other states have developed transport bans where no restraint systems are required, that a violent patient essentially
Sure.
can get back there and could hurt themselves. I have to testify on a case where a patient jumped out of one of our ambulances.
Oh, sure.
It is not a safe place to put it.
It's not.
A potential psych patient. It's just not safe. And so adding the word EMS and/or appropriate legal authority would really comply more with what we see in the state law now.
Do you want to just take out EMS and say transport directly, that could be transported directly to, take out EMS personnel?
Sure, medically stable patients can be transported directly to psychiatric
Yeah,
facilities.
because it doesn't matter who takes it,
Right,
right?
doesn't matter who takes it.
Yep. So just delete whom EMS personnel and put in who?
Yes.
Your English teacher would be very proud of you.
Yeah, that's my mother.
The Attorney General ruling by Greg Abbott was that the psych facilities cannot statutorily require that a patient go for a medical screening exam at a hospital.
Sure.
And that the sheriff's department
Can
take them
transport.
directly to the psych hospital. So if we put in EMS, they're gonna just say, well, you just told us.
Yeah, well, but we also want to enable somebody to take them directly to a
Correct.
sobering center
And/or whatever.
and/or other
facility.
crisis intervention center.
Which is not occurring all over the
No.
place. This is,
Yeah, I think I would recommend just taking out the EMS and just say transport directly to, regardless of what that transportation is. That'll be a local jurisdictional decision.
Dr. Manifold, your area is probably the leader in this. Do you have suggestions or?
No, I think the changes in the wording are fine. My one question was going to be, can we anticipate any other unintended consequences of this language that goes with this?
Usually not.
Otherwise, it wouldn't have been unintended.
Usually it's a big surprise to us.
I think,
I was just curious because, this is kind of, it's an area that's a little bit difficult to put into exact words, and
Right.
I'm sure there'll be additional discussion at GTAC before it moves forward.
Yeah, I think probably the term that would come up is this, quote, abandonment? But
Well, I
I
think
think
that's
that's why we
You're
need
gonna
this.
have the buy-in of the psychiatric community. I mean, you're gonna have a partnership there or this won't work at all, so.
Well, but some of the sobering centers don't include much of the psychiatric, I mean, it's the mental health authority, but not psychiatry. They're not involved at all,
I
in good, bad,
think-
or otherwise.
the big concern by some will be is that if you transport them to an alternative destination, then you can't bill for it. And so then we get back to the whole fraud issue in EMS. But I think the bigger issue is that now some of the payers are realizing that please transport them directly to the facility and bypass the ER and save us a few $1,000s for an unnecessary medical clearance. So
Right.
the payers are now starting to figure it out. It goes more with integration as we change the accountable care that's provided. The only thing that I would, I think it's insinuated in there, but somehow that with medical direction or protocols driven for medical clearance is something that a physician, the medical director is the one that is deciding the protocol for the medical clearance, and that kind of owns it back to, as we've always done in Texas, it's my practice of medicine. If this is something that I choose to do, then allow me to do it.
So, and I absolutely take your point there. How about if we said determine, and again, this is on line 3 for those who can see it, determine if there are medically stable patients who, comma, with appropriate medical direction, comma, could be transported directly.
Yes. It's good.
It's like you've been working on this for weeks, man.
Say direction to medical oversight.
Months.
That way it doesn't imply an online
right.
call, yeah. It's never 8 at night, it's
Ever.
3 in the morning.
That's why they love to call you Dr. Moore.
All right, so I'll take this forward to GTAC because it is on the agenda. Are there any comments from the audience, from the public on this particular item? And I realize you can't see the changes Dr. Jarvis has made because they're not being projected. Nothing? Okay. So then I will call for a vote, and I hate to beat it to death, but can you read us the final language one more time? And we'll take it as a whole unless somebody wants to stop on
Why
each
don't I
item.
just make a motion to approve with changes discussed?
Second.
Y'all don't want to hear it again? You're good? All right. There's a motion and a second. Any further discussion? All in favor? Say aye, please.
Aye.
Aye, please.
Aye, please. Very good. Anyone opposed? Okay, it passes. I will take it to council on Monday. If you could email that to me, and I will get it to them.
Jeff, will you email me that?
And actually, how can we send it to Jane too? Or if you send it to me, I'll send it to her. Or you send it to her and to me. We'll get it around. Next item, actually number 2, was brought forward by Dr. Phillips, but I believe we are all familiar with it. I do not know if we have it to project it. Starla left us. Is everyone familiar with the NAEMSP, American College of Surgeons, joint statement on the use of long spine mortars by EMS personnel? And the request was that this committee basically either rubber stamp it, make comments, or forward to GTAC for its recommendation. That's 7-0 LSU, just so you know. I just thought I'd point that out to you. For the state to disseminate to the state.
Yeah, I like the document. The only problem I have is that it says mobilization as opposed to stabilization. If it's a 2-year-old kid, the mobilization isn't going to happen. Other than that, I think it's very germane.
Okay.
I'll tell you, when I saw that, I said, well, this will be great. I'll incorporate this into my scope of care, my protocols. well, we've already been fairly aggressive about doing field clearance. And when I put that in there, what this document is really talking about is backboards. And it still says if you have a patient and gravity in the same room, put a C-collar on them. So what I found is that when I incorporated that in, it really sort of confused what we were doing. So I had to do a lot of gymnastics to work my way around that. As soon as I did it, I sent it out and asked my medics for comment. And they said, so really what you're saying is, what are you saying? Because you're confusing me. And what I finally got to was, if you cannot clear them clinically, like we've been doing, essentially the nexus criteria, then they get the full meal deal, C-collar and backboard, comma. If, however, there is a reason that the backboard would cause problems, kyphosis or prolonged transport time, or going through the act of putting them on a backboard would cause more motion, i.e. standing takedowns, then just forego the backboard altogether and secure them to the stretcher. And I think that seemed to sort of get around
So you gave them the discretion to opt out if that's the thing to do.
Correct, right. What I basically did was used this to say if you can't clear them, then do the whole meal deal unless there's a reason the backboard would be a problem, since the backboard's not really doing much good anyway.
I think for the American College of Surgeons, this is an MSP and ACS. All the emergency agencies think this doesn't go far enough. The problem is the ACS has agreed to this. And this is a starting point. I mean, you're starting to see these discussions all the time, and there are people that adamantly disagree with these positions. But we all agree that something has to change. So I don't know if much it's a rubber stamp, Bobby, or Chairman, I'm sorry, as much as that I think that the medical directors should probably draft a statement that things are continuously changing, and that backboards, here's the evidence, here's position statements that exist, that we highly encourage local medical directors and agencies in their receiving facilities to reevaluate the use, or something to that statement, or something to that other than pushing the statement, because I like Jeff, believe it doesn't go far enough. There are others that are even doing what this says is probably going to be a big leap, because it's past their comfort zone, because they're not traditional EMS or ER physicians. So,
do you think that it would be useful if there were another, perhaps a local Texas document that said it is appropriate, with appropriate medical direction, for systems to essentially go past this? In other words, write a position statement saying field clearance is appropriate, is safe, appropriate, and the literature supports it.
I agree. It would be a great move for our state to lead anything. But it would be nice if we could, I think we all could as a group, come up with the evidence that exists, this being one of those references, and probably come up with a nice statement that a lot of operators or EMS providers are going to want to go to their medical director who's not involved and doesn't know what the heck we're talking about, and really support those. I would even go forth with making a recommendation of we should start on a lot of issues we're going to talk a little bit later, start drafting suggested protocols that people in the state could take to their medical director, and here, this is from GTAX Medical, would you be encouraged of designing something like this or writing a protocol like this for our agency, or just adopting the one that the medical director. So
Does anybody on the committee have a problem with us endorsing this even as like a starting point? And I can draft some language for the council on Monday. Is anybody opposed to anything that is in here, thinks anything is in here is harmful?
I'm not opposed. I think you just have to give yourself the wiggle room, or give us the wiggle room in that language, because the American College of Emergency Physicians is coming up with a statement. They didn't sign on to this one because they had some other concerns as well, and I think they're trying to be a little bit more liberal. And so I think there's just going to be many variations on the theme, and I wouldn't want us to get trapped into saying this is the only one we find.
Right. I definitely think we don't want to say this is the standard of care, because I agree, this does not go far enough.
Right.
And let me even break a second. Out in the audience, how many services are even doing clinical clearance by paramedics? There's supposed to be more hands than that, because there ought to be a whole lot.
How many services are not doing any clinical clearance in the field? And then nobody else answered. Okay, that's good. So,
And I would dispute
I-
that.
the
because-
thing is, I think it was a big surprise to me, because in my services, we've been doing clinical clearance for longer than I can remember.
Yeah, everybody's clinical clearance at some level. You have to ask them, do you have neck pain, et cetera. It's whether it's formalized and
Yeah.
protocolized.
How many of you have a formalized process for clinical clearance, not paramedic driven? You know, I mean, that would be a
Yes.
better question.
Yeah.
Yeah, I think language that indicates this is a step in the right direction, and again, notates this is a matter of local medical direction would be better.
Yeah, I think the thing is, when this came out, I read it and I went, well, that's nice. They're finally coming up into the 90s. I was surprised there was some pushback by some people thinking, oh my God, this is awful terrible. You can't possibly do that. So I was very surprised at how some people thought this was a very modern thought. So I think we at least need to let the council know that we think this is a good start.
How about if we did two things? One is vote to say yes, we think to essentially endorse this document as one way of addressing this problem. And then as a separate issue, we draft a position statement on essentially a review of the literature supporting field clearance. So it's a separate position statement, but don't hold that up.
Okay, so that's two motions. We'll take the first motion is endorsement of this, or at least non-opposition. How's that? We say that, because I think we've been asked, what do you think about that? And we say, well, we think it's a good start. It doesn't go far enough. So you have a motion that we endorse this as a start. Is there a second to that? Somebody say second.
Second.
There you go. Anyone opposed? Okay, I will take that forward to the council. The second item is, you think that we should come up with a position statement? / protocol / whatever?
Yeah, so what I would recommend is that the medical directors draft a position statement in support of field clearance with an appropriate review of the literature.
All right. And now it gets quiet, because the question is, who's going to do that?
I'd be happy to take that on.
Yeah.
Who was that?
I'd be happy to
Excellent.
take that on.
Dr. Spear. Yay. Anyone opposed to that?
I am absolutely unopposed to Dr. Spear doing that.
All right.
And the position papers for clearance of
What exactly do we want Dr. Spear to address? Which I think, and one, for those of us that have formal processes already, please forward them to Dr. Spear.
Yeah,
Are you specifically talking about field clearance of?
Field clearance, yeah.
Field clearance of?
I would say the position statement should have basically just a brief literature review on field clearance, and then say that we are, this group, and ask for GTEC support, supports field clearance.
I'd also like to see let's create a sample protocol for those who would like help that don't know where to start. And if we could all send those protocols, I'll help Dave, and we'll write a paper with some good references, and then have a sample protocol that those who would like to adopt some type of protocol clearance that I think would help a lot of agencies.
Okay.
Maybe everybody who's doing it, all of us support our protocols too.
Yeah.
And do we want
RACs
to do
not
this?
already have that?
I would say, do we want to do this with the foresight that there may be additional clinical issues that we would address down the road in a similar manner, in a similar format?
I completely agree. I think there's going to be a lot of these things that are changing what everybody thought we knew, and that I think that's the purpose of this committee, that we should take these controversial issues. I mean, even to the fact of the psychiatric clearance. I mean, there's great protocols for medical clearance for psychiatric patients, that we should start this trend of statements, evidence-based statements with suggested protocols for those agencies that don't have involved medical directors and maybe need some help writing some protocols.
All right. Excellent. Next on the agenda, and so I don't forget it, and actually I'll put it in together, agenda item number 3 and agenda item number 10. We have two members of the committee who are finishing their tenure, Dr. Phillips was finishing his tenure on this committee, and Dr. Serbaugh opted not to go for reappointment. Those two gentlemen are retiring from the committee. We did reappointments to the committee. Some of you, actually, you had to turn in an application. So reappointed to the committee are Drs. Beeson, Bradley, and Moore. And then added, and I can go ahead and talk about this, I'm assuming, are Dr. Troutman, who I saw earlier. I don't know if he's still in the room. There he is, Dr. Jared Troutman. And then I think her first name is Catherine Remick. Is she here? She is from Austin, and she has been appointed to the committee that will start in February.
How do you spell her last name?
R-E-M-I-C-K. So, and we had, we were in the fortunate and unfortunate position of having to say no to, I think, 4 or 5 applicants to the committee, which is, it's good to have applicants. It's a shame we had to say no. Next item, item number 4 that was brought out at the last meeting, I think by Dr. Moore, Dr. Beeson. I don't know if you've had a chance to work on it. House Bill 434 regarding blood draws.
It was passed, as I understand.
Right,
Yeah.
it was passed, but there was discussion about, it's passed, it is currently in effect. Would it go in-
It gives several outs.
Use
Number
the-
one, the medical director has to approve the use of the medic drawing the blood. It has to be a sanitary place where it happens. It has to not interfere with the usual care of other patients, so that if you're busy and you can't do it, you can't do it. And there has to be immediate chain of custody of the sample that goes straight to whoever gets it. As far as I know, those are the things that are in the law that affect us.
It has many things talking about supplies and things that aren't discussed in here. I think the biggest issue that this does not discuss that I think is going to put our providers in kind of a weird position. It does not talk about consent at all. Because literally police now, based upon the law, can go and forcibly take a blood sample. And all of us that work in ERs where they bring these people in know how that goes. The last thing that I think we want any of our providers on the scene, or even worse, I've been called by some of our local police officers or agencies here in Fort Worth wanting, well, can't our certified first responders go ahead and do this? Is them getting called out in the middle of the night, not on a medical call, but to some scene or to the local jail to do a forcible, non-consenting blood draw. So I suggest, or what I'm offering is to get with Bill, and I would like to write something up as a position on this, and even to the point of, once again, drafting a sample protocol for those that are choosing to adopt this, to discuss the things about consent and describe what a sanitary environment is and those kind of things, to hopefully go farther than what this does, if those who choose to do this or not. I think it's a big issue in rural settings. They're not going to have to, transport somebody hours away to get a legal blood draw, but the last thing we want is fights to get blood, and somebody's going to get hurt.
So we discussed this issue in my county with our county attorney, and I included a statement in my protocol that said we will not be doing this. We will not do blood draws solely for the purpose of determining illegal substance concentrations, even at the specific direction of law enforcement. And that was even at the specific direction came from our county attorney, who said, let's just make it real clear and then distribute that to all of the law enforcement agencies so there is no doubt that they cannot order us to draw that blood, that we're not going to do it.
Why I went solely, I shut all our police departments up because I asked them to go to the city's attorneys and to find what sanitary was, and none of them came back. So that was just another way to deal with it. So.
We just trained our law enforcement agents to draw blood, which seemed to help solve the problem. So.
I thought law enforcement was excluded from drawing blood.
No,
Yeah, I
it has-
thought the law didn't have them listed. It has specific lists of who.
As long as they're trained. The wording here, I'll find the wording.
really?
word
Oh,
for it.
okay.
Like the number 2, qualified technician. doesn't
Right.
exclude.
So you make them a qualified technician?
Right.
Oh, okay. All right. Sounds good.
So do we need to take action on this? It was brought up at the last meeting. We couldn't really discuss it because it wasn't on the agenda.
It's a law whether
So-
we do it, so, but we want, as a group, to have a position statement.
Right. Dudley?
Dr. Beeson, I think you're spot on. So,
Colin, can you say that again?
I think you're spot on.
Hold on, let me get my recorder out.
Do you
here.
want that
Go
in the
ahead,
minutes?
go
We
ahead.
don't do
I'll give you the
minutes
date and
before
time.
the
It's on tape, good.
And we can
good.
agree on some things and disagree on others, but but prior to this passing, the bill specifically excluded EMS personnel in any way, shape, or form. And there's been a handful, especially one representative out of the Northwest Houston area, who was adamant about EMS personnel being able to do this. And at first it just added it to the list, and at the time it said a law enforcement officer can order, and it was just added to the list with physician and phlebotomist and all that. And the ambulance industry came together with the prosecutors and got all of these language changes made that you see, because first of all, we wanted the service to be able to opt out. You have to opt in if you want to do it. So if you don't write a protocol, your medics can't do it where it'll stand up in a court of law. So you guys kind of hold that key in your hand already. It's the pieces that aren't necessarily addressed in there. Our medical director was a little bit concerned about the liability on a fighting patient as well. I know you've seen that in the hospital when they bring these patients in. I did this multiple times in Florida, and they fight really well until you get right next to them with the needle and they settle down most of the time. But a lot of those things that were put in there were put in there to protect the service, because we recognize this was aimed at the rural areas where there is no hospital nearby. We got to get the blood draw done because somebody has been killed or very likely killed. They're just not dead yet, and so they're going to do the mandatory blood draw. But we still wanted to protect the medics, so they couldn't be taken away from patient care. They couldn't do all those other things, and by not putting them in the chain of custody, hopefully avoid them getting subpoenaed into the courtroom as well. So I think you're spot on with the direction you want to take with this. I think a sample protocol would be huge, as well as just reminding folks, if they don't want to play, don't write the protocol. And then their medics, an officer can still try to get them, but it's what I used to tell the officers prior to this law coming into effect. I'll draw your blood for this DUI, I'm happy to, but it's going to throw your case out of court because I'm not allowed to. And that's still really the thing if we don't write the protocol for it. So.
Only thing I would say is that we will write both we're going to do it and we're not going to do it, because I think not writing a protocol is not a good thing. It's going to put a provider in a situation where it's like, well, I haven't been told I can't do this. So we need to have a statement for those that aren't going to do it that says.
The protocols say requests for blood alcohol, drawing.
Well, and there is the other venue outside of areas where they have medical examiners where the JP can order a blood draw on a dead body to determine the same thing. So, and that's written actually much more tougher than this is. So.
So within, say, 2 days of that law passing, I started getting a ton of questions from my medics. So that's the reason we specifically addressed it. I agree with you. Not writing the protocol, I don't think was clear enough it may work great in some places, but I didn't think it was clear enough. So we were very clear about it. And we're also very clear that it only applies to living patients. Because then, my issue is an ethical issue, and it is a crew safety issue. I don't want them hurt in the scuffle. I'm pretty sure that if the dead guy is going to hurt them, then perhaps we need to refine our
probably have a
assessment
deeper
skills.
DUI issue there. And I think that's probably fair. There was a big push to try to get medics doing this, and when we got together and the prosecutors wanted. I mean, their conviction rates in the high 90s when they have blood versus blowing. So they want it badly. And it came from our medics almost immediately as well, because the police officers whose chiefs are tired of hauling them to the hospital and getting grief from the hospital said, hey, we have an out. So.
Not so fast.
Yeah.
Okay, so who's got, and Dudley, while you're here still, I saw the email you sent out, the stakeholder report. Did you send that to all the members of this committee?
Yes.
Okay, thank you.
Hopefully, if your email address is correct on the DSHS website.
Okay, thanks. So.
Dr. Moore and I will work on it. We'll get back to the next meeting.
Yeah.
That was just way too easy.
Yeah.
Wow.
That's easy.
Excellent. And from what I'm hearing, you're going to write basically, I don't want to say sample protocols, but you're going to give rationale for doing it and for not doing it, both to, you're not going to say, we
Pick
think you
your
should or
side.
shouldn't. You're going
Pick
to give
your
them.
side.
Okay, good.
The guidebook.
Got it.
Pick
We will
your side.
address House Bill 434.
Okay.
If you choose not to decide, you've still made a choice.
Do
Yes,
you?
You have chosen. Choose wisely.
Does the committee think that's something we would be able to do in a single meeting and I could take to the council?
Yeah, you can put it on the agenda next time.
Okay. I mean, I'll put it on the agenda for this and I can request it to be placed on the council committee. And I will report that at council and see if there's other committees, for example, EMS, that may
We'll-
want that.
Dave and all the things to work on, I would just suggest we do things and send out for obvious suggestive changes. Obviously, everything will come back to an open meetings where it'll be discussed.
Right,
but,
yeah.
um,
Okay. All right, so that will be a position statement. Gotcha. Y'all are closing up your computers. Is the score not going well for you here?
No, my battery's not going well.
Oh, okay. I was just asking.
What is the score, by
What
the
is the score, by the way, Dr. Ellerby?
I have no idea. I'm focused on matters at hand.
Yes.
Unlike our sheriff.
Yes. Tigers are winning. Okay.
Cameras behind.
There a camera behind us? Yeah, there is.
Focused on your laptop.
Yeah, so, okay, item number 7. Dr. Beeson, you're up again. A report on Trauma Systems Committee Registry Work Group. Is there such a thing?
So I'll
A
give the
report
cliff
for this
notes.
committee.
There's beta testing going on in the Panhandle somewhere, right, Jane? Yes? Yes, and the biggest thing is, I guess I'll bring that's ongoing is the providers and the trauma the trauma committee representatives and others. There's been a push, or I guess a movement or suggestion to be able to share data. Right now, the registry is designed to just give data to it, and then they do what they do with it. And it was brought up in one of the meetings, well, if I'm going to share data with them, why can't I get data back? There was concerns and discussions about some of the privacy things that maybe the trauma hospital doesn't want other people to know about, and so that's kind of where they're at. But they said it is feasible to be able to push and pull and share data between the transporting entity and the receiving facility back and forth. And so that's kind of where they're at, and when more changes, I'll let you know.
Anything this committee needs to do or needs, you're
Not at
keeping
this
an eye on it?
point.
Okay. All right. Sort of last agenda item before we go to public comment, number 9. I don't know how many people are aware of this. I don't know if Jody is still in the room. There was a change in a recommendation by, and I'm not going to remember the exact state organization, but it's not a state organization that we advise. Is it Texas Higher? Oh, you know all this stuff, yeah. So it's what? Texas Higher Education Board. The coordinating board, there you go. There he is. About that all associate's degrees in the state of Texas would be 60 hours. A number of paramedic programs or EMS professionals programs have more than 60 hours. I understand there's been a fair amount of work done on this since we first heard about it, and I'll probably be better off just turning it over to Mr. Harbert, who looks like ready to tell us about this.
That's you.
Is that me?
That's
okay,
right.
good.
Yeah.
Thank you. Jody Harbert, Tarrant County College, GTech Education Chair. There's been a lot of talk, and I will tell you from the Texas Higher Education Coordinating Board, this kind of slipped by everybody. It just appeared all of a sudden one day pop, and we started to look, and their recommendation is that all associate degrees go from a max of 72 hours to 60 hours. We asked why. Why all of a sudden are we dropping 12 hours? It came down to really looking at finance. We have a lot of people who've been using grant money, who've been using scholarship money, that have 50 hours, 60 hours, never declared a major, and still getting financial aid and keeping on going. So part of their thought was that we make all associate degrees 60 hours and all bachelor's degrees 120. Most of that was so that the money, when you reach 60, unless you've gotten your associate, we're pretty much cutting you off from scholarship money. If you've reached your bachelor's, we kind of want to cut that off to have more completers. That was probably one of the big ones. We've been looking at this, and we will talk extensively during our meeting that follows yours on some ideas, but we really want to hear a lot from most of the programs, because as many programs as there are, we're finding out we're working on some workarounds. One of the big, not workarounds, but one of the big things that we think might be helpful is Texas Higher Education Coordinating Board actually put an exemption in for certain programs that could show that they needed to stay at 72 hours. And I think most allied healthcare programs are looking at what they're trying to do, have figured we don't need to go to 60. We need to find this exemption, and we need to stay where we are. Now, to trim a couple hours over here from your core curriculum, because what happens is, in certain programs, depending upon how many hours you have in a core curriculum, that begins to affect faculty load. When you affect faculty load, you affect number of employees. You affect number of employees, you affect jobs and salaries. And this is not just for EMS, this is every associate and every bachelor's degree, regardless of discipline. So this has worldwide, countrywide looking at it to say what's the best thing that we need to do. And today I'm really looking to hear from a lot of our colleagues, because we've been emailing this around to figure out what everyone's looking at and what everyone's doing, and then we want to look and see. Probably won't get it done today, but at our next work group meeting in January, figure out a direction. Probably everyone that I've talked to is leaning more toward requesting the exemption, to say that we leave these hours where they are. Personally, if it requires a license, a certification to go with it, I don't think we have a problem looking at 72 hours. Certainly if you're looking at something that doesn't require a license or cert, pick anything in academia, nothing against academicians, please. But if we need to take something a few hours back there, fine. But I think as medicine grows, nursing grows, allied health grows, PTA, rad tech, whatever, you start going through, for us to cut those hours, I think makes the degree not only less desirable, but I don't think it would share the same force that it would if we left it at 68 to 72 hours. So we'll have a lot of discussion in our meeting. That's kind of the nutshell behind it.
So this was originally a law passed to save money for scholarships?
It was to save money because we had so many people working, getting and receiving scholarships, grants, whatever, with 50, 60, 65 hours, never declared a major, no degree, and we're just kind of keep on going. Where are you going, sir? Well, I'm going to take another course and see what happens. So they were looking for some standardization so that they could say, you know what, if we've got X number of students, it's going to take 60 hours to get them out. We can kind of budget a little bit better because now we know. Well, some programs need to be at 60. We might have some rural programs that 68 is going to work best for them. We may have some urban programs where 70 or 72 is going to work best for them. So I don't think we have an answer yet. I think this is the first meeting that we've had that we can sit down as a group to start to look, discuss, figure out where the issues are, and then move forward.
So last couple of site visits I've done with COA, this came up. I was just in Maryland a couple weeks ago. They're trying to standardize all educational programs at community colleges and other things, because some associate degrees are 50 hours, some are 75 hours, depending on the major. So they passed this law that, of course, had financial implications, trying to cut things off. The problem's going to be, I know NIMSY's dealing with, I think NSIMSO's been discussing some of these issues. The issues are going to be that EMS programs can go for these exemptions, but the fear is that the financial aid programs are going to say, no, we're only paying for 60 hours. If you want something more than that, it's going to be out of your pocket, which is going to make the paramedic programs undesirable because people aren't going to get financial aid for it. So it's going to be a multifactorial issue that it's going to have to come, and it's most states have this law. So when it kind of snuck up, it really didn't. I mean, it's been an issue going on the educational standpoints for a while. I don't think people really thought that it would.
I think
go
that was it.
like
People
it did.
didn't think it would happen, very much like a lot of other things.
Right.
But yeah, it's going to have.
And it's going to have huge implications because they say, okay, then we need to push it to baccalaureate programs, which is going to push paramedic education out of community colleges. So it's a big issue, but McDonald can fix it.
Any other questions? Do you need anything from us, since you're primarily working on
To see
this?
you at our meeting afterwards.
Okay,
Absolutely.
all right, cool. Yeah, I think this group is probably in favor of education. I'm thinking. We did more than 72 hours to get where we got. I think we're all okay with that. So that is actually all of the agenda items that we're going to go over. Before I ask for public comment, summary for the GTAC council, for council. I will take forward our position statement on mental health, which we just approved. I will recommend endorsement of the NAMSP EMS position statement on spinal mobilization, with the caveat that we are working on additional guidance. And for what would be the February meeting, I will state that we would like to submit a position statement on EMS blood draws. Did I miss anything? For our next agenda, I have Dr. Spear is going to work on a draft position statement on the field clearance with the sample protocol. Doctors Beeson and Moore are going to work on the ETOH, or the blood draw. And then early on, and this is something I threw in with our discussion about the requirement to use ambulances, that if we could have some kind of a position statement on that. Is there anybody that has an interest in starting that? If not, I will.
Utilizing ambulances for non-emergent, is that what you're saying?
Well, not just the general concept. There are hospitals that require an ambulance for any patient being transported out.
Okay.
Some guy has a hand laceration and he's going 100 miles away to see a hand surgeon. They make him take an ambulance. He gets there, he's stuck. He's stuck with a bill. He's stuck with no transportation.
County's stuck with an ambulance.
Yeah, the county's stuck with no ambulance, and he
Sure.
never needed an ambulance to begin with.
Change
But
that
the
in
hospital,
the transfer sheet.
yeah, the hospital quote policy is,
It's not an entire requirement.
yeah, it's not, the hospital quote policy is they have to go. We don't
Okay.
own the patient, so you can't force them anyway. But it leads to a lot of problems.
I think that'd be something that'd be interesting, since most of these come out of ER, that we should probably work with TSEP. And that's probably an issue that we should push up to TSEP, and TSEP should really come up with something. I mean, we'll be more than happy to help, but
Ira will do that.
Ira?
Ira,
Yeah, he got it.
Ira, we're on it, Ira.
Big eyes.
You weren't paying attention at all, were you? See, you don't pay attention, now you got something to do. All right. Then finally, we have only a few minutes. Any general public comment? And is Rebecca Brock here? Because she sent me an email about something she wanted to talk about, but I can't because it's not on the agenda. I don't know her. All right. Any public comment at all?
Mr. Chairman, while there's waiting for public comment, there is one announcement. The Drug and Safety Act has been passed by the House and Senate and is waiting to be signed into law by the President, and that will potentially affect compounding pharmacy and agencies and our ability to use compounded drugs in the pre-hospital environment. So just an awareness item for agencies.
Okay.
To the negative, right?
To the negative, correct.
Yes.
Could, I'm sorry, since I think that does affect lots of people, I've missed that. Can you just explain what that?
So it's a over 300-page document being signed into law. So once you get done with the Affordable Care Act, you can move on to that. But one of the bottom lines is it's essentially tying that compounded medication to a specific patient. So in the traditional sense, it would require a prescription. The last time that I looked at the bill, I haven't seen the final version, is that you will have a time period after that medication is administered, but you will end up having to send some type of documentation back to the compounding pharmacy that essentially matches up that medication was administered to this patient.
So
you can't have
Each use?
Yeah.
each use.
So what it does is, where we carry a medication for a just-in-time administration, it has to have a prescription for an individual. The individual will have the drug compounded and go back.
So in other words, EMS cannot use compounded agents?
Pretty much nobody can in a just-in-time. It'll do away with it.
All right, well, BLS ambulances are in good shape then.
Yep, not bad.
Well, there will be none.
Well, I don't know. Remember, D50 is one of the things that we ran out of, so.
Absolutely.
one other thing that we put on the agenda next time is the president's new statement, literally telling schools to start stockpiling EpiPens.
Oh.
And now the price of EpiPens and the dual things are 160 or 180 bucks a pop.
They're already unaffordable.
Yeah, they're already unaffordable. Either we should start our own company, or we should
Compounding company? Compounding company?
compounding. Could talk about that and the implications to BLS services that are mandated to require something that's more likely going to expire on the ambulance.
Right. Well, they're mandated to hold it, to carry it, doesn't mean they can use it. All right. I don't see any public comment. Unless somebody's opposed, we're going to finish early. We are adjourned. Thank you very much. Stay warm. What's the score? There we go. Yeah.
To 2?
No. When he says